Hello, I'm Catherine Stevenson, the American Chemical Society. Welcome to this news briefing from the ACS Fall 2020 Virtual Meeting and Expo. We're joined today by Dr. Russell Pesavento from the University of Illinois at Chicago. He's studying how to stop tooth decay before it starts without killing bacteria. Dr. Pesavento?
Thank you for the introduction, Catherine, and the opportunity to discuss research today. I really appreciate it. So our group is really focused on using inorganic chemistry to solve some of the challenges in clinical dentistry and oral medicine. So kind of a backdrop for the research, I thought a good way to start this presentation would be to address what dentists look for in an exam and a cleaning. And then we can get into the microbial sort of etiology behind tooth decay and odontogenic infections. And then we can also discuss what we have, the sort of chemistry available to us right now to help promote the best oral health among patients. And that's really a good lead-in to the research that we're developing. So having said that, I have a model set of teeth right here. And what we have is the lower teeth here. We have a molar and a couple premolars, okay? And what you see is the crown made of enamel. And then what you don't see is the root surface that's embedded in the bone. And then, of course, on top of the bone is connective tissue and the gums, or the gingiva, which we call it. So that's the pink color here. And these are the crowns made of enamel, which is pretty much comprised of calcium, phosphate, and hydroxide. So the purpose of an exam and cleaning is to have you leave with teeth that look like this, right? To have them look nice and clean. But what we often see when patients come in, and we do recommend they come in every 6 months, what we often see is we see something like this. So this little pipe cleaner sort of demonstrates the plaque or biofilm growth at the gum surface. So we see this typically after several months after the last cleaning. And what it really is bacteria. It's their way to adhere to the tooth surface. So they secrete this sort of sticky matrix that allows them to continually stick to the tooth surface. And if you're eating a diet that's high in sugar, they continually metabolize the sugar and produce acidic byproducts. And if that's left unchecked for several months, a lot of times you start to get decay of the tooth surface. So the acidic byproducts sort of eat away at the enamel. And then depending on how long that goes unchecked, you can have into the dentin, you can have more advanced tooth decay, and you can lead to things like crowns and things like that, and root canals. But so that is the etiology behind tooth decay, okay? It's really bacteria-based, and there's usually a few key players involved. Streptococcus mutans is one of the bacteria that's most common associated with tooth decay. So in the course of an exam and cleaning, of course, we want you to leave more like this, right? Where you have these sort of pristine teeth. The problem with that is if you don't go back to a sort of nicely scheduled tooth cleaning, flossing, within a matter of hours to days, you go back to the sort of plaque that's built up. That's how quickly it begins. So to help the patients out, what we typically do is talk about the agents that can promote the best oral health. So we're talking about fluoride, okay? We all know about fluoride. That's been around for a long time. And you may ask how that works. Well, fluoride works by sort of coating the enamel surface and making it less soluble. So it doesn't dissolve in the presence of the acid challenge, either from beverages or from the bacteria that are metabolizing the sugars. So that's one way to do that, okay? And we still recommend that. Another agent which I'd like to talk about is the use of silver diamine fluoride or silver nitrate. So that's typically used when the patient already has decay and doesn't choose to restore them for a variety of purposes. So what we do is we paint a little bit of silver nitrate on the tooth surface to arrest the decay. It really kills the bacteria. Sort of the challenge with that, though, is it often leaves the tooth structure brown or black, which is not aesthetically pleasing to most people, okay? So if the teeth are in the front that we're trying to look at and restore, it leaves you with a smile that's a bit stained. So those are some of the agents that are out there, and that really kind of gets us into what our research is focused on here at UIC. I'll put this down here. So what we decided to do was use the template of silver, okay? So silver agents are already applied in the oral cavity, but we wanted to use it in a way, we wanted to use an agent that could help prevent the biofilm to begin with. okay? Not necessarily after the fact, after the tooth already begins to show signs of decay. So what we decided to do is to focus on a different metal ion using the template of silver, but we're using cerium, okay? Cerium is an ion that has been used, a metal salt that's been used medicinally before, but we chose to use it in this study for a variety of reasons, which we can get into a little bit more if you'd like. So we basically published a manuscript in the spring. There was a couple goals that we set out to do. We wanted to look at cerium, the different salts of cerium, as well as the cerium oxides that can form, and those are nanoparticles. So what we did is we compared their activity in limiting the adherence of a specific bacteria that I mentioned previously, Streptococcus mutans. And we did in vitro experiments. So we're basically setting up the bacteria, giving them sugar as if it was in the oral cavity, even though it wasn't at this point, and we let them secrete their biofilm. And what we found was pretty interesting. We found that even though these cerium oxide nanoparticles, we used a few different sizes of them from commercial vendors, and we made one in vitro. So what we found was not all of them inhibited the biofilm. In fact, none of them did under these conditions except one. So the one that we found, even though it was similar in size to other nanoparticles that were commercially available, we found that one particular one that we sort of synthesized in vitro that's been known previously had the biggest effect on the bacteria from actually sticking and forming that nice, robust biofilm. So there's a couple of conclusions we reached when publishing this manuscript. One, I guess the first principal one, was that so the size of the nanoparticle matters in limiting the biofilm adherence of these strep species, specifically Streptococcus mutans, but also the manner in which it's made. And we're looking into that a little bit more. That's a chemistry issue. The other thing that we found that was really interesting is these cerium oxide nanoparticles that prevented or had the best activity in limiting the adherence of the strep mutant species did not kill the strep mutant species. So when you use similar amounts of silver, which I talked about previously as an agent that stops cavities from progressing, you would have killed the silver, but this just didn't kill them. It didn't really let them have a nice adherent biofilm. And the third conclusion we reached from this study was that compared to silver, if we're looking at toxicity in the oral cavity, we used a couple different human cell lines that sort of replicate the oral environment. We had less of a toxic effect on those cell lines than silver did. So those are the three sort of principal principal conclusions that we drew from this study. Now, having said that, we're very proud of this publication, and we'd like to move on, and we're also excited about developing more clinically relevant models. So the in vitro study was a nice place to start, but now we're just now getting to look at, does it allow or does it permit the biofilm to stick on a tooth surface, an extracted tooth? And I did not mention saliva, okay? So saliva is a very tricky place to do chemistry. So we're going to start incorporating saliva in our models as well to see if we get the same activity. And one of the other things that I didn't specifically mention is, although these nanoparticles that we did prepare, they worked pretty well. However, they're made in acidic media, which is often a challenge of metal oxides. So we know that continual application of an acidic media to the tooth surface would not be favorable to the tooth surface. So we're also looking at ways to stabilize this nanoparticle now at a basic pH or neutral pH, so it's less harmful to the tooth surface. So at this point, we also want to see, does it have activity in the presence of fluoride? Of course, we're not going to stop recommending fluoride. It works very well, but it works via probably a different mechanism than what we're looking at with the biofilm. So potentially down the road, if the study progresses in clinical models, potentially you could use two different modes to prevent tooth decay, one from a structural point of view with the fluoride, potentially one from a bioactive point of view with something like the cerium oxide. So that's where we're really going with the research, and we're really excited about it. And I'll be happy to take any questions related to either dentistry or the cerium oxide nanoparticles.
Great, thank you. Are there any questions from viewers? Please state your name and affiliation in the chat window when you ask your question. While we wait for questions from viewers, I have a few myself. What led you and other researchers to consider nanoparticles as a way to protect teeth?
So there is precedence already for the use of nanoparticles in the oral cavity. There's a hydroxyapatite-based nanoparticle that's incorporated in some toothpaste. There is nanoparticles as well, and depending on what type of composite, the white fillings that we use. So the precedent was there, but what we wanted to do was capitalize on the chemistry of cerium. And the beautiful part of cerium oxide, is that those nanoparticles form quite readily. And nanoparticles typically have an enhanced surface area. So the chemistry that is happening is usually sort of more pronounced than the individual metal ion, but also what you have is a way to coat the surface. So if you're seeing properties that you don't necessarily like in your studies, you have a way to tune those properties because they are nanoparticles. So if you're seeing toxicity, or if you'd like to potentially increase your reactivity, they make it nicely. The nanoparticles are made in such a way that they're nice to sort of tailor to what you're looking for. So that's basically it. The use of cerium has been used previously medicinally. It's been used as an anti-burn agent. It's been used as an anti-emetic agent. But there's a number of reasons why we wanted to start with it. In addition to the fact that it previously had shown some anti-biofilm effects. One was that the salt that we start with is pretty cheap. Which is good from a point of view. If you want to be able to treat many patients, this needs to be cost effective. The other property of cerium-3 and cerium-4 to some degree is that in the presence of the ligands that you might find in the oral cavity, most of the products that you see are faintly colored or white or faintly colored. That is very attractive when you talk about wanting to coat something on someone's teeth. You don't necessarily want byproducts that are going to be deeply colored. That tends to make people not want to get the treatment. You can get away with it in the posterior teeth to some degree with silver. It works great. People tend to like it in the posterior, but not necessarily in the aesthetic region. So that's some of the reasons we decided to use cerium. Yeah.
Great. We have a question from Kath O'Driscoll from the Society of Chemical Industry. She asks, how far have you got with making potential coatings that are stable at the pH of saliva?
Well, we haven't published it yet. We're in the process of writing that manuscript now, but we do have a particular coating that we're looking at right now that's been giving us activity very similar to the uncoated nanoparticle for inhibiting the biofilm, or at least making less adherent biofilm. So it took a quite of a screening process to find a nice polymer-based coating that we could find that would actually sort of make these nanoparticles exist at a pH that's tolerable to the oral cavity. I think I did mention the silver diamine fluoride. That pH is pH 10. So that's what we apply that agent to the teeth in the oral cavity. If that pH goes below 5 or 4 in that area, you start promoting demineralization of the tooth, and that's kind of counterproductive to what we're actually after. So like I said before, the oral cavity is a very tricky place to do chemistry, but it's very challenging, and that's why we're doing what we're doing.
We have another question from Kath O'Driscoll. What is the modification for gingivitis as mentioned in the press release?
So it's along that same lines. Basically what we're looking at is we did look at some of the bacteria that are involved in gingivitis. So gingivitis is a little bit different than dental caries. The players are different. Okay, it's not necessarily attributed to strep mutans. It's some of the early strep species like Streptococcus oralis is one of them. So what we wanted to do is basically create this pH stabilized nanoparticle and see if we can repeat this on some of the bacteria that are associated with gingivitis. And we found similar effects with this bacteria. It's yet unpublished though, so we're still sort of pushing forward with that. But the players are a little bit different in gingivitis, and they definitely change when you're talking about something like periodontitis, which is an advanced infection of the gums. So gingivitis is the early stages that you see, and one of the agents that you do use that's in Parodontax, I believe the toothpaste, is stannous fluoride. So we're looking to address it with more robust studies as well as far as our gingivitis models.
The press release mentions that other researchers didn't have any luck with cerium oxide nanoparticles. What made you persevere despite those findings?
So the nanoparticles that showed the most activity That was first published, I believe, in 2017. And as far as I could tell, the group, when we were working together, these have yet to be tested. And we wanted to stick with cerium for the reasons I discussed previously. So that was part of the idea, was we can screen several of them, include this new species of cerium oxide that was, I think, recently published in 2017, that was yet untested. And I'm glad we did, because it provided us with a new set of data that we weren't necessarily expecting, and we're building off that right now. So it was really the fact that, I keep harping on the fact that nanoparticles are a product of how they're made. If you change the synthesis, you've just changed the nanoparticle, and you potentially just changed the bioactivity. So that is definitely an underlying concept of nanoparticle chemistry, and we knew that going in. So by seeing a different methodology, that allowed us to suspect that we possibly had different bioactivity as well, but we needed to do the test to confirm that.
Another question from Kath O'Driscoll. Could the cerium nanoparticles have applications in other coatings, such as medical devices?
We're open to that idea. We need to address these in our studies with the chemical coating. So if we can stabilize these like we think we can right now, stabilize these nanoparticles in a way that they don't decompose in a complex environment, either it be another catheter or something like that. Even toothpaste, right? A toothpaste, believe it or not, is extremely complex, what's in your toothpaste. And if you're talking about something that's metal-based or metal oxide, a lot of times they have a high surface area. So it's really a challenge to keep the bioactivity, yet stabilize it at the same time. So that's where we're directing all our efforts right now. So it's a very good question. We're open to that, but it really sort of gets down to, can we stabilize it in that environment and yet retain its bioactivity? And we have not gone that far yet. That's a good question. I like that.
And another follow-up question from Kath. She asks, you mentioned that Streptococcus mutans are not killed by the cerium nanoparticles. Is this advantageous over agents that do kill the bacteria?
So that brings up a very interesting concept. So in the oral cavity, if the plaque or biofilm cannot adhere to the surface, presumably it's easy to wash it down, and you end up swallowing a lot of those bacteria. So if the bacteria cannot necessarily adhere to the tooth surface, what you have is a situation where you won't really get cavities, because the cavity is basically a manifestation of a prolonged biofilm on the surface. So by killing them like silver does, that will also stop decay. But what we're looking at, and as of yet non-tested, is we're thinking that the oral microbiome is a very complex place. It's estimated there's over 700 species of bacteria. So we'd like to put the least amount of pressure on that system as possible. Killing them indiscriminately sort of puts a little more pressure on and selects some bacteria over others. There's no perfect way to keep this balance if you introduce chemistry in the oral cavity, but we think simply not allowing them to adhere to a surface would be a less dramatic way, allowing us to perturb that microbiome less than you would had you be just sort of indiscriminately killing. So that's the idea, and that is also, those studies are also going to be planned down the road to see what effects we actually do have on something like as complex as the microbiome. Yes, very good questions.
So how long do you think the nanoparticle treatment would last? Would dentists need to apply it after every cleaning?
Boy, these are some good questions. So what we're looking at is, like I said, I kind of keep harping on the stability concept, but it depends also on which mode of application. We're at the early stages. There's things like varnishes that you paint on the teeth, like your fluoride at the end of an appointment. And then there's things like mouth rinses. So it really depends on the mode of application, which we're not that far yet. So it also depends on how stable it is in saliva. Now, that is a concept that's, as I mentioned previously, doing chemistry in the oral cavity is extremely challenging. So it really depends on how well these nanoparticles function when saliva is present, and if they can be still active when present on the tooth surface. Those are our next studies planned. So when those studies sort of bear fruit, either way, I'll have more of an answer as to how often they would need to be applied. But we really need to find out how active they are in systems that replicate the oral cavity.
Could these, if they wear away from the teeth and are ingested?
So you're asking if they would be harmful potentially?
Yes.
So you guys are mentioning some very good questions. So that is, we're just now going to be testing their toxicity on cell lines of the lower digestive tract. So we're going to start testing there, because that's absolutely right. You put something in the oral cavity, you're going to by default swallow some of it. So that is our next set of studies, and we want to compare both the coated and the uncoated versions to see if there's a difference in toxicity as well. So yeah, that is our next set of experiments, because that is something that's very real and very possible. Just as up to this point, we've only published on cell lines that are sort of unique to the oral cavity, not the lower digestive tract. So that's the next set of experiments, yes.
There are growing concerns about the effects of nanoparticles on health and the environment. Can you address that?
So yeah, this is a common theme, and it really comes down to the concept that I talked about a little bit earlier, is how they're prepared and what their activity is in their environment. So nanoparticles are very much a product of their environment. So whether something is present in the bloodstream versus something that's present in the saliva, they take on the environment that they're in. So their activity sort of replicates the environment that they're in. So although we do completely agree that we have to test these in a more robust manner, and we're going to continue that moving forward, we don't think a one size fits all for nanoparticles. I don't think that necessarily that you're going to get toxicity in every environment that you put them, because of the principles that I just said. So while we do agree that we need to test them, I think it's environment. It's basically environment based, whether their effects are toxic or not.
And what needs to be done before the nanoparticles could be used in a dental office?
So there's several things. We're at the beginning. So we've done the in vitro studies, and the next thing that we're up against is two things. We really need to demonstrate their success on a tooth surface in the presence of saliva. But one of the concepts that I didn't necessarily mention in the biofilm discussion is that it's usually not just one player involved in cavities, even though strep mutans is the predominant one. They're polymicrobial. Biofilms are polymicrobial in nature, so we'd like to make some more advanced biofilm models as well in the presence of saliva on extracted teeth, as well as address the toxicity issues that you mentioned, testing more cell lines, higher concentrations, see what we're up against. And again, the fact that they're nanoparticles, even if we do see some sort of toxicity, being able to tailor them with a surface coating may be a way to sort of address those challenges if they do come. But we'd hope that we retain activity, which is always the challenge when you start manipulating the surface.
Thank you. The archived version of this session will soon be posted at acs.org/fall 2020 press conferences. Please join us for our next press conference tomorrow at 9 a.m. Thank you.